All right. Welcome everybody to our November Journal Club with the American Osteopathic College of PM&R. I'm Nick. I'm one of the co-chairs for the research committee. My other co-chair is TJ. Go ahead and say hi, TJ.
Hello. Hi, Dr. Amstutz.
Hey, TJ.
We are so honored and excited to share with you guys our guest speaker for this evening, who is Dr. Diane Amstutz. Dr. Amstutz is a clinical psychologist. She did her graduate work at Northern Illinois University and completed her internship in Chicago, where she has served as a rehabilitation clinician for a number of years. She now is she has been with Shirley Ryan Ability Lab for a number of years now as a clinical psychologist, and currently serves as the program coordinator for the pediatric pain management program. She recently actually co-authored 2 chapters in the pediatric rehabilitation textbook, one of them on pediatric chronic pain and the other on functional neurologic disorder, which is the topic for this evening. Without further ado, we are so honored to have Dr. Diane Amstutz.
Thank you. Yeah, as Nick said, I've been in rehabilitation, I won't say how many years because it gives away how old I am, but more than 30 years, working with both adults and children. I do now primarily work with children in an outpatient pediatric pain management program, as well as with pediatric inpatients. But I've dealt with FND, with functional neurologic disorder, for many, many years. I will say, as an aside, that I think in the last couple of years, whether it was COVID related and stress related or whatever, definitely have seen an uptick in these diagnoses. Now, is it because, you know, the stress of everything going on in current life is causing more of this disorder, or is it because we're just finally getting better at recognizing and diagnosing it? I can't tell you that, but it's really great that you guys are here. I appreciate you giving me your time, because it's so important to understand what this diagnosis looks like, and especially important for people who are interested in rehabilitation, because we are kind of the last stop for most of these people. And if we understand what it is and how to treat it, it's of a tremendous advantage to these patients. So this disorder has had a lot of names: conversion, psychogenic, psychosomatic, dissociative. You can probably think of some other terms as well. In 2013, the APA decided that they would call it functional neurologic symptom disorder. It's sort of been shortened to functional neurologic disorder at this point, but the idea is that there isn't any physiological abnormality, but the brain networks are not functioning properly, and the patient has one of a number of various deficits, which we'll talk about. There are genuine changes in motor, sensory, and cognitive performance. People have, you see people who we call have the minister of funny walks. They have all these non-physiologic gaits. Some people report paralysis or numbness. Some people report brain fog or cognitive fog. There are also people with speech issues and a whole variety of other symptoms. But the symptoms are they tend to resemble a neurological dysfunction, except that when you start to do medical testing, blood work, MRIs, fMRIs, those kinds of things, you don't traditionally see what you would expect to see. You don't see the physiological deficit. This is from the chapter that I authored. It's not from the article that we sent you, but I think it's really important because Katya Kozlowska, who's a psychiatrist in Australia, and Australia is so far ahead of us in this, it's kind of scary, because they've really got a good handle on how to handle these issues. And she talks about functional somatic symptoms. So she goes beyond just FND and talks about the fact that there are functional neurologic symptom disorders that include gait issues, speech issues, and what we call non-epileptic or NES seizure disorder. That used to be called psychogenic non-epileptic seizures, but again, we've since removed the word psychogenic because it felt like it was pejorative, and now it's just called NES non-epileptic seizures. There are functional gastrointestinal disorders that include abdominal pain, nausea, and vomiting that you probably are familiar with. There are chronic pain syndromes like fibromyalgia, headache, and chronic regional pain syndrome, CRPS, all of which appear to be very functional in nature. Chronic fatigue syndrome is another functional somatic symptom disorder. And then if you're familiar at all with dysautonomia, you know that we've increasingly been diagnosing people with, excuse me, getting over a cold, sorry, postural orthostatic tachycardia. So if you think about this as more than FND, but as a large range of disorders and issues, you can see that many of the people that you are going to see in clinic, many of the people that you're going to see in inpatient rehabilitation have these diagnoses, and they're really considered functional in nature. So I brought this slide. They talk about feigning in the article kind of far back, and I really brought this slide to the front because I want to make it clear that these are not people who are faking. They're not deliberately going, I think I'll pretend my arm doesn't work, right? There are things like factitious disorder where people are faking their symptoms because they want medical care or medical attention. There are also Munchausen's is also a disorder like this, the Munchausen's by proxy, where people invent symptoms because of the desire for medical attention and medical care. Malingering is deliberate faking for some other kind of gain. When I think of malingering, I think a lot about the workers' compensation patients that you may be seeing who maybe they still had a slip and fall and now they're paralyzed, and they're coincidentally suing their company, and so they're deliberately producing medical symptoms in order to get some sort of gain. And as it notes, that's a conscious deception. And when you see someone with FND, they're not consciously unable to walk or unable to speak. It's a very different pattern of FND is a real disorder. It's seen all around the world. And if we get into the weeds of it a little bit, some of the neurophysiological imaging studies, the fMRIs and such things, have actually found some subtle differences between people who are deliberately malingering and people who have FND. So although it's not an always reliable way to diagnose those issues, it's interesting that we are starting to notice those things. This is also Kozlowska, not in your article, but I think it's really worth talking about because when I talk about FND to patients, I literally have this on a laminated sheet that I bring out and I start to explain. Functional symptoms are a result of an overactive brain stress system. So what's the brain stress system? If we start at the bottom, the hypothalamic pituitary adrenal axis gets activated when the brain is stressed, when the brain is in that fight or flight response, right? It starts to produce cortisol. And that cortisol has an impact on other parts of our body. You guys know that. So the autonomic nervous system gets activated and you can end up with motor and sensory deficits. The autonomic system either is overactive or sometimes in the case of functional abdominal symptoms, underactive, but it's not functioning normally. And it leads to, again, an uptake in those fight or flight symptoms, increased heart rate, blood pressure, sweating, muscle tension, and so forth. When the brain stress system is overly activated, our circadian clock gets out of whack. You see patients who come in and their sleeping is kind of all over the board. They don't have regular sleep cycles. They may not be getting deep sleep, again, because the activation of the stress system. And then that immune inflammatory system also gets activated. And that's what produces a lot of the functional pain disorders that we see. And then treatment for that really is activity, right? It's really about restoring activity so that you can reduce the immune inflammatory response. But if we think about the brain stress system involving all of these aspects, it really does help us explain to ourselves and to patients what's going on in functional disorder. This is another kind of complex but helpful diagram that sort of speaks to the previous diagram, right? So what are things that predispose us to FND? Having pain syndromes or having previous functional disorders like irritable bowel, other neurological conditions, migraine, epilepsy, right? Psychological disorders, stressful events, anxiety, depression. childhood adversity, ACE, right? You've seen that, adverse childhood events. Many patients with FND, when you begin to get a history from them, will report abuse, neglect, or other adverse childhood events. And then there are genetic risk factors. It does appear that FND is somewhat, can be familial. Sometimes it's hard to find that vulnerability. You don't see, it's hard to find those predisposing factors. What are precipitating factors? Again, this is sort of a repetition. For movement disorders, someone who may have had a limb injury. For seizures, someone who's had a fainting episode or may have had some epilepsy that was well controlled by medication, but then develops these episodes sort of out of the blue. A brain injury can sometimes predispose people to functional cognitive disorders, even after they've, again, recovered from the brain injury. And dizziness can be related to VPPV and other vestibular pathology. And then all those psychological factors can also obviously predispose to FND. It also talks about comorbidities, and it talks about those emotional factors again. Irritable bowel, chronic pain, overactive bladder, persistent fatigue are functional things that predispose to having those diagnoses. What keeps this disorder going? I think the one that's most important for you to notice is the diagnostic uncertainty. That can be a doctor who says, I don't know what you have. You know, I just saw somebody yesterday who came to us and it was apparent that they had a functional disorder. They'd been seen at one of the better medical facilities here, which has a large teaching hospital. I won't say which one. And the neurologist, instead of having the courage to talk to this patient about what was going on, said, I have no clue what's wrong with you. I'm going to send you to Shirley Ryan. They'll tell you what's wrong. So not being able to present a reasonable case for what's going on. Sometimes patients will get a good explanation and they will reject it and have uncertainty themselves and feel that they're not safe and need more testing. Other things are misdiagnosis is another condition, poor communication, like, I think you're crazy. I think this is just because you're nuts. So I'm sending you off to wherever. Lack of interventional treatment, unnecessary investigations. We see people who've had that $1 million workup, right? Their file is like this. They've had every conceivable test. And maybe there's something like maybe their ANA is high, which is not uncommon. Maybe there's some other small, slight issue. Maybe there's some mild abnormality in the MRI, which as we start to know now is not uncommon for all of us. And they've just been going from doctor to doctor to hospital to Mayo Clinic, right? Trying to find out what's wrong. Sedative and opiate medications can exacerbate these conditions. Avoidance of issues can make it worse. And then people who are not motivated, who have discovered that their functional symptoms actually give them some gain, right? And have lack of motivation to change. So how do you treat this? Explain the disorder, provide interdisciplinary treatment, and treat any existing comorbidities. That can result in good recovery. So again, a very busy slide, but it helps you kind of sort through what's going on with these folks. It's all ages. I have seen 5-year-olds with FND and I have seen 80-year-olds with FND. So it really does run the gamut. More female than male. Females are specifically more likely to have non-epileptic seizures. It is the second most common reason to see a neurologist, followed by after headache, right? That is astounding. Think about that. Think about all the neurological issues, stroke, Parkinson's, Alzheimer's, right? Second most common. They think about 300,000 people a year in the United States have this diagnosis. The cost is over $1 billion. And again, the problem is that most people in healthcare don't understand this diagnosis. Again, we talk about those predispositions and precipitants, family dysfunction and bullying. It doesn't always have to be something dramatic or huge. It may be somebody who just feels like they're getting picked on in school, or they've been made fun of on social media, or mom and dad are arguing more than they used to. It doesn't always have to be this dramatic event that can precipitate it. There's often some coexisting depression, anxiety, or PTSD. Patients who have this diagnosis often also have either chronic pain or IBS, very common in these patients. We talked about the fact that adults almost always have an exposure to adverse childhood events and stress. What do we know physiologically about these people? They have decreased 24-hour heart rate variability, which is, it's a little counterintuitive, but as you know, heart rate variability predicts positive functioning, and low variability predicts negative physiological issues. There's also some recent research that suggests that people with FND have a defective oxytocin receptor gene. And again, there are a few studies that have talked about this. It's not widespread. It's not something that I have honestly seen tested in any of my patients. But I think as we get to know more about this disability, we will start to understand and start to see more tests coming out that help us predict what really is going on. Illness and injury can predispose. So again, somebody who's had a fainting spell, an epileptic seizure, a migraine, somebody who's had a fractured limb or some kind of motor injury. Again, physicians are often reluctant to give this diagnosis. And unfortunately, the prognosis currently is kind of poor. 40% of adults were unchanged or worse after 7 years, and only 20% went into remission. I believe with children and adolescents, the prognosis is better because they're obviously more malleable, more flexible, and if we're able to get in early, we can often make some significant changes. But there isn't, and I know because in writing the chapter, we were asked to look at what's the remission rate for children, and there really is almost no literature whatsoever out there about children and FND recovery. We're going to talk about several different functional diagnoses. Nick didn't say anything, but if anybody's got a question, please ask it. Please feel free at any point in time to go, hey, I got a question about this, because I'm happy to answer them. Sometimes when we do this and you have to hold your questions, you're not old like me, but if you're old like me, you'd have forgotten your question by the time we were done. So feel free to jump in. Functional seizures, again, called non-epileptic seizures. A lot of times what you see with these folks is they develop a certain panic, okay? They respond to some previous, maybe they had a syncopal episode, they respond to this autonomic arousal and they get conditioned to it. So I've seen patients who will be talking along and go, and then they're back and they're talking again, right? And the mother's like, look, they're seizing. And you're like, I don't think that's seizing. So it's difficult to diagnose whether or not it's non-epileptic, because you can have epileptic seizures and they don't always show up on EEG. The gold standard is to do at least a 48-hour EEG, so you're trying to capture things. I have seen multiple EEGs of patients who were having episodes of seizures. They were seizing at the time, and when they looked at the EEG, nothing looked different. Nothing looked abnormal. So that is relatively predictive of a non-epileptic seizure. The other thing you need to think about with all of these people is that the symptoms they present with are inconsistent. They're not always present. So, for example, a patient with a non-epileptic seizure, I had an adolescent recently, and she only happened to have these seizures at school. Never had one at home. No, that's interesting and probably pretty unusual, right? People who are, unable to do a task at one time, but perfectly able to do it when they're distracted at another. So one of the hallmarks that's going to be important for you all as physiatrists is to not only get a good history, but to kind of look carefully for those inconsistencies that you see in capacity and ability. What are other signs of a functional seizure? What do you want to look for medically? A prolonged attack. Some people will have these hour-long events, right? Hyperventilation, right? Post-ictal tearfulness, right? Post-ictal responsiveness. So they have the seizure and they're back and they're fine and they're talking and things seems to be amiss. And then asynchronous limb movement is also a sign. So you want to kind of know what are the hallmarks, what are the things to look for when you're evaluating somebody who's complaining about seizures and no one's been able to find what's really going on. Functional movement disorder. So another category here we can talk about. Any abnormal movement, it might be a tremor, might be dystonia, myoclonus. Mostly what we see are paresis, paralysis, and this kind of non-physiologic gait. Do you know what I mean by that? So they have a walking pattern that cannot be explained physiologically, right? You're watching them walk and it's really unusual. I know I have this later on, but I had a patient who would picture this in your mind, stand up straight, take a step. As soon as they took a step, did a deep knee bend with both knees, popped back up, took another step, did a deep knee bend. I mean, this is really hard to do. Like, try to walk down the hall like that. And it was much harder ambulation than it would have been to walk normally, but that was his gait pattern. And we're like, doesn't make any sense, right? So seeing these kind of non-physiologic gait. Voluntary movements are disrupted, but habitual reflexes are intact. If you do reflex testing, it's intact. The symptoms often come on kind of suddenly, like I woke up one night and I couldn't walk anymore, or I woke up and I couldn't use my hand to write. They often have anxiety, fatigue, and pain. Again, we talked about fluctuation of symptoms during the day, even in the course of the hour that you're examining them, positive psychiatric features. And what you really want to do is be good at distraction, right? Compare movements when you're asking them to do something with movements that they do spontaneously, right? And one of those things we talked about was the Hoover sign, which you probably know. A patient is laying in bed, you put your hand under their unaffected limb, under the heel of the unaffected limb, ask them to raise the affected limb. They can't, but you will feel them press down with their unaffected limb, right? And so it's using those, knowing those kinds of tricks or diagnoses can be really helpful for you. This is a newer diagnosis that's related to some extent to POTS and that postural orthostatic issue, except they don't seem to have a dysautonomia. This is one of those, say it 5 times fast, persistent postural perceptual dizziness. So these are people who come in and complain of a chronic dizziness. Dizziness is a frequent reason people go to neurology, for example, and it's hard to define. So you'll say to patients, is the room spinning? Are you lightheaded? Because dizziness means different things to different people. But these are people who complain of dizziness. They appear somewhat unsteady. They're swaying or they're rocking. It's made worse by patients' movements or when they're in a visually complex environment, their dizziness seems worse. It may be initially related to something like benign paroxysmal positional vertigo. They may have vestibular migraines. There may have been a mild TBI or some dysautonomia. So there are some structural issues that then set off this kind of chronic dizziness. These are people who have a lot of body vigilance, and that can lead to their dysfunction. So they're relying more on visual input than on any feedback from their body or vestibular input. So they develop this chronic dizziness that can be treated often by vestibular treatment, legitimate vestibular treatment, and it can help people kind of come back to integrating somatosensory input with visual input and decreasing dizziness. One of the things you want to find out with people who are dizzy, who are having seizures, who are passing out is what happens when you pass out. So one of the hallmarks of people with FND is they don't hurt themselves. They will fall or they will pass out, but they don't hurt themselves. Almost never have I seen someone with FND actually get hurt. I've seen them fall, but it's something about the disorder that the body protects itself. So I had a patient, again, who was passing out all the time in school. And you can imagine that if you're a student and you're standing between the desks and you pass out, what's going to happen? You're going to hit your head, right? You're going to end up with a mild TBI or concussion, or you're going to, right? So, okay, how many times? I passed out 40 times at school today, not making that up. Okay. So what happened? Did you get hurt? Ever get, nope, never got hurt. Ever hit your head? Nope, never hit my head. Right? People with functional gait disorders who are falling all over the place, but again, never get hurt. That's a very telling sign that this is a functional disorder, and that in some way the body's preserving itself, but the action is going forward. Functional cognitive disorders. Sometimes you hear people talking about brain fog, right? I can't think clearly, I can't remember, I can't concentrate. When you do neuropsych testing with these people, they have very variable patterns of deficit. And they might have deficits on neuropsych testing, but you find out that they're going to work every day and they're performing their job just fine. So there's, again, that inconsistency. We distinguish these FCD from neurodegenerative disorders because they're almost the opposite. So if you've ever interviewed a Parkinson or particularly an Alzheimer's patient, they'll be like, my memory's fine. I don't know why my family's complaining. There's nothing wrong. These FCD patients are just the opposite. They'll come in and go, last Tuesday, I couldn't think of my nephew's name. And yesterday, I forgot where I put my car keys. And 4 days ago, I walked into a room and I didn't know what I wanted. I didn't know what I went, right? These are things that we all experience, but these patients remember those deficits very clearly and specifically. They're a lot of times seeing neurologists for memory issues. They're more concerned about their symptoms than the people around them. The exact opposite of someone who has a real functional disorder, who is often completely unconcerned about it, right? It is true that some patients with FCD do later go on to develop dementia. And it's, what does that say? Maybe they have this sense and so they're hypervigilant. It's hard to know, but it's not always the case for sure. They seem to have an abnormal awareness of their own thought processes. What they're experiencing is what healthy adults experience. Even if they perform well on cognitive tests and you say, wow, you got a, you were over 90% on your memory recall, they're like, no, I wasn't. You're just telling me that. Like, so they don't tend to understand or believe feedback. It is also true, as you all know, that anxiety and depression can exacerbate cognitive issues and cognitive symptoms. What's the pathophysiology of these disorders? It's a loss of voluntary control over some kind of function in the body. New neuroimaging is showing abnormal activation of the right temporal parietal junction. These, again, are very new studies. I haven't seen a lot of this. There are a few fMRI studies that seem to indicate that we can start to distinguish between the brain of FND and with other disorders. They don't attend to objective body signals. So again, I have a patient right now who walks with her right leg completely stiff-legged. She does not flex her knee as she walks. She walks with a very stiff leg. But she comes into my office, sits down, and bends her knee normal. Right? So she can bend her knee. She just doesn't want to do it when she walks. She's fearful of falling. And she feels that keeping her knee straight will prevent falling. So she's not really paying attention to what her body's telling her. Her body is telling her when she sits, she's perfectly able to bend her knee. But as she walks, she isn't getting that same feedback. These people often have an increased attention to symptoms. So deliberate movements are very difficult for them, but if you can trick them into doing automatic things, you can see normal functioning. Some fMRI studies, as I noted, also are showing changes in the limbic system. They tend to have increased cortisol. We talked about that as part of the HPA axis, and lower heart rate variability. Again, there are also some new studies that talk about differences in gray matter and basal ganglia volume. So that's all, in that article that we just discussed. And these, again, if you want to know more, these are very much newer findings in the last 2 or 3 years that they're developing these tests. So what are the pitfalls? You're the doctor, you make the diagnosis. What are the problems and the issues? It's important not to jump to a conclusion. Somebody comes in, they look a little wacky, they tell you they've had depression, and you're like, it's functional, right? So don't do that, right? You have to consider other medical causes. The psychiatrist who trained me had a quote, nothing more embarrassing than a dead hysteric, right? So don't assume that you thought this person was hysterical and now they're dead, right? So make sure you're investigating symptoms fully, okay? How can you miss a diagnosis? So how do you miss this diagnosis? You don't ask patients. I saw somebody the other day, again, from this high academic center, completely missed the diagnosis. All I said was, what's been stressful? Well, both of my grandmothers died in the last year, and my dad had COVID and he's not able to work. And my little sister's autistic and she gets all the attention. I mean, it was like a litany of stressors, which nobody ever really asked her about. If you don't understand what FND is, you don't know how to pursue a diagnosis. It's important, as I said, to look at laboratory findings, but not to like look for those little kind of zebras, those incidental findings that may not be significant. I think unwillingness to make the diagnosis is enormous. If one thing I hope you guys get from this, it's that you don't, you're able to have the courage to tell patients, this is what I think is going on. I see all the time that patients come from very, again, high academic centers in Chicago, and nobody's willing to say, I think you have a functional disorder. I think that this is related to physical stress, emotional stress. I think there's a way to around this. You have to have the courage of your convictions to make this diagnosis for people. Make sure you explain it based on positive features. Here's what I see that makes me think it's functional, right? Make it clear that you're not saying they're crazy. Make it clear that you know they really have these symptoms. Make it clear that they're medically safe to proceed, that we don't need to do further testing, that we understand what this is, and try to avoid saying what it's not. I've seen doctors who say, well, you don't have cancer and you don't have MS, and well, that's not helpful. Tell them what they do have. Explain to them what's really going on. Make sure that you refer them for interdisciplinary treatment. We're going to talk about that in a minute. If they're on benzos or sedatives, remember that can worsen the condition. Give them online information. There are online support groups. There's a group called Hope and some other support groups that can be helpful. Try to connect. So if we see patients who've seen neurology and mom's like, when we've got 4 more appointments with neurology because we're going to do this, and this, you might call that neurologist. You might call that, cardiologist, whoever you're working with, and say, this is what I think is going on. Could we hold off on some of that testing? Because again, the testing can just kind of precipitate more and more anxiety in some of these folks. Let's see. So again, don't tell them they're a mystery. I don't know what's going on with you. Please never say it's all in your head. That's immediately patients stop listening and you're done. What do? Interdisciplinary treatment. The patient and the team all are on the same page about what's going on with the patient. Everybody agrees. You talk to the patient and say, interdisciplinary treatment has a good chance of success. If we all work together as a team, we can help you get better. You can reassure them that there is hope in terms of recovery. If you're the physical therapist, you want to use as much distraction and look at preserved automatic movement. So for example, if somebody's having difficulty walking, I've seen the PT put colored dots on the floor, right? And then the patient has to say the colored dot, or if there's a number, say the number on the colored dot, or take that number that's on the colored dot and subtract it from 100. I mean, like whatever you can do to distract them from the fact that they're walking, right? Having them say the alphabet backwards. I mean, anything you can think of that begins to work for them to distract them and get them back to more automatic dysfunction. Because what's happened is we often tell patients it's a software problem, not a hardware problem, right? Everything up here works, but the way it communicates with your body is out of whack. It's not working. Your brain and your body are not communicating. And so if we can distract your brain and get your body moving, that can be very helpful. Vestibular rehab for those with the persistent dizziness can be extremely helpful. With OT, we talk a lot about function, helping you get back to bathing, dressing, vocational types of tasks, talking to them about pacing and taking breaks and not just pushing through things. Obviously, psychotherapy is a critical piece of this. The cognitive behavioral therapy, helping them understand, helping them to just decide what their stressors are, whether they're physical or whether they're emotional, whether they're both, and then giving them the tools to manage those stressors. So teaching them how to think differently, giving them tools in terms of mindfulness, teaching guided relaxation, focusing on sleep. Kozlowska emphasizes focus on the body first and then later the brain and the stress. So we always work on sleep and sleep hygiene. Once you can get somebody to sleep better, they're going to function better. Focus on teaching them relaxation tools, some really concrete things they can start to do. For PTSD, patients with bad PTSD, if you read FOA, it's all about exposure, talking about the frightening event, stopping when you feel too distressed, going back and, talking again about it, exposing you to that scary event until you are having fewer nightmares and flashbacks. Teaching stress reduction is the critical piece. What can you do in terms of your physical activity, functional activity, emotional activity to reduce the stress in your life? SNRIs and SSRIs can really be helpful. If you've got somebody who's got depression or anxiety, you can use those medications. I use hydroxyzine a lot for anxiety because it's not a benzo. But you can use those medications to help improve mood and function, and that can be extraordinarily useful. So, questions? Anybody? I, kind of gave you the thumbnail sketch of it, but anybody have questions about this or questions about things that I've seen or experienced or anything I can answer?
Yeah, I have a go ahead.
No, please, you go first. You go first.
Oh, okay. I was going to ask Dr. Amstutz, so I guess the overall goal then for treatment, is it so that patients then automatically do movements that I guess we would consider like normal, but have become not normal for them because they've adjusted, say, for example, like that gait example, so that like that person's walking normally without even thinking about it? I guess, is that kind of the end goal, I guess, for that type of patient?
Exactly. And that not thinking about it part comes kind of late in the process, obviously, but we actually have this goofy thing we call steps to success. So patients come in and we give them a literally stair step. We say, okay, you're not walking. I want to walk normally, right? No assistive device. And we actually will use assistive devices with these people. So if I've got somebody who's not walking at all, they're not going to get up and just go across the room the second day I see them, right? So we start with a walker, right? Or a cane, or what, loft strands, whatever. And we give them that device until they start to get more comfortable. And they're like, gee, you're doing great. Let's try a cane now, right? So the goal is to just start to restore that, software, that brain body connection in a normal way. And it's interesting because we actually had somebody who we saw him for 6 sessions. He was the best patient in America. He was just a great kid. He had started high school and got completely overwhelmed and got behind. And that was it. Stopped walking in a wheelchair, couldn't move, right? Brought him in. First day I said, park your wheelchair and walk into my office. He looked at me like I was crazy, but he did it, right? He was able to do it. And we were just able to kind of help him, give him the confidence to begin to move to the point that by the time he left, he was running. He was able to function totally normally. And part of what we did is we also required him to go back to school. So we made him sort of face that thing he was frightened of. And it turned out the school was like, we didn't think you were so, stressed out, and we can give you a tutor for your math. And we could, right? And they were more than willing to kind of accommodate. And once we addressed that primary stressor, things got better very, very quickly. And that doesn't always happen. We kind of hit a home run with that one, but you're right. The goal is to restore as much normative functioning as possible. Okay, TJ?
Oh, well, that's a pretty drastic experience. My question was going to be, what was like the biggest recovery you've seen someone get? And like,
Yeah.
I think that answers my question.
That's one of them. I've seen younger kids who one of my favorites was a girl who came in and her voice, she talked like this all the time. You know, and you're like, So she started out being mute, and then she talked like Mickey Mouse, and then eventually she started to talk normally. Her movement, her physical movement was pretty intact, but she just had gotten stressed out about some family dysfunction and some fighting, and she shut down. So she was kind of mute, and then we moved from mute to Mickey Mouse and Minnie Mouse, and then from Minnie Mouse we moved to normal. So that's, I've seen those kinds of things, and it's not, that's why it's such an awesome thing to treat, because you get to see those things happen.
Right. So I guess my follow-up question, because I see we have someone with their hand raised here. I'm sorry, one more question. My follow-up question is, how long does it generally take for a person to start seeing like tangible results? And I know everything's different, right? So
that's the $64,000 question. And again, the young man I talked about who was not walking the day came in, and 6 weeks later, totally functional, right? I've seen FND patients for over a year, right? More than that. The shorter the course, obviously, the better. As they move quickly, it's a much better prognosis. But it's really about finding that combination, kind of hitting that home run. And it's not always easy to do. It's not like, with the kid I just talked about with the school stress, it was really apparent that he was super stressed out about school, and nobody had really explored that. And once we explored it and we got that fixed, it was better, right? That was pretty straightforward. But a lot of these kids are complicated. They've had abuse issues. They've had, all kinds of other things going on. I can't tell you that COVID has made it better for particularly kids who I see. So it can be a very long, extended process. Sometimes they come for inpatient treatment and then come for outpatient. So I've seen as little as 4 weeks, 6 weeks, and as long as a year or longer. And there are a cohort of people who never really do get better. It's very, very sad, but it's true.
I think Urgent, you have your hand up.
Yeah, hello. So my question is, what differentiates FND from a psychophysiologic disorder?
Well, tell me what you mean by psychophysiologic disorder. How would you define that?
So the definition I am working on overall right now is it says it's a clinical term for overall mind-body symptoms. So symptoms that are caused by neural pathways that develop in response to stress and trauma, and that end up giving the patient very real, very debilitating symptoms, similar to what you were talking about. So it seems like there's a lot of overlap. I was just wondering if there was a clear distinction between the two.
No, I think there is a lot of overlap. I would agree with you. And then you're thinking about something like, one of the old examples used to be like a stress ulcer. So stress causes a real physiological dysfunction, like causes a gastric ulcer kind of thing. Is that what you're thinking about?
Yeah, it can be with that. It can be with a lot of just a lot of like musculoskeletal pain, migraines, different irritable bowel syndrome, fibromyalgia, all of
Yeah, and there's enormous overlap. If you look at that first slide, fibro, migraines, those kinds of things are often considered functional in nature, meaning they're brought about by an interaction of the brain stress system and the body, right? So there are a lot of weird labels, a lot of weird words. I think we're moving more and more towards not using those psychophysiological diagnoses, not using somatization, not using conversion for sure, but just cause that umbrella, that third slide, maybe where it says functional somatic symptoms, just calling these all functional symptoms, and then defining what are some of the precipitating factors and how do we deal with those. Does that make sense?
Yes, no, thank you.
Yeah.
One follow-up question. is there, with your patients that you deal with, how is the interaction between you as the physiatrist versus a psychiatrist that they may also be working with? And what is the overall overlap there? And with treating these patients, especially with FND, do a lot of psychiatrists also treat FND in different ways? And is it like, do obviously a lot of PM&R folks also do? What is that overlap? Because the overlap is what I find extremely interesting in this.
Sure. So I'm a
With-
psychologist, so I don't prescribe. The physiatrists that I work with tend not to prescribe psychotropic medications because, again, it's not their specialty, and they don't have the capacity to follow these patients long term for their psychiatric issues. So if they're not seeing psychiatry, we recommend psychiatric follow-up, which, as you know, right now can be difficult to obtain, but we recommend that, and we will consult with the psychiatrist and talk about if there is pre-existing depression, anxiety, PTSD, those kinds of things, nightmares, whatever. Then we'll talk to psychiatry about becoming part of the team in terms of prescribing medications and working with that patient. But that, and here at Shirley Ryan, that's done separately. I think all of us here would love to have a consulting psychiatrist on staff. We don't. A lot of rehab hospitals don't, which is super unfortunate. But we do ask them to get into a psychiatric facility if they can. A lot of the public aid patients and patients with other medical insurances can't always do that, but we do recommend that. And we will work with, we'll talk to psychiatry about what we're seeing. They will talk to us about why they're prescribing what they're prescribing. And a lot of times, even after they finish our program, they're going to continue to follow up with psychiatry to fine tune medication. Did that answer your question?
Yes, thank you so much.
Sure. All right. Well, I know, guys, how limited and how stressed all you are in terms of time. So I'm very privileged that you took a few minutes to listen to what we have to say. I don't know, Nick, if you sent my email out, but if anybody has further questions or wants to know more about FND or anything like that, feel free. I'd be happy to chat with you about it. All right. You guys were great. Thank you very much.
Dr. Amstutz, it was an honor. Thank you so much for your time and for all of your hard work and for sharing your expertise with us this evening. I know it was crucial for us as future physiatrists, and I definitely think we all learned a lot from this presentation. Thank you again, everybody, for attending. I am happy to send out Dr. Amstutz's contact information to those who I sent the link. With that, thank you all for your time and have a good evening. Thanks again, Dr.
Come on, guys. Take it easy.
Yeah,
Take care.
thank you so much for everything. This was wonderful.
Oh, sure.
Thank you.
Enjoyed it.